Good evening, and thank you for joining us for Treatment Options for Enlarged Prostate, BPH, presented by Dr. Daniel Arrison. Dr. Arrison sees patients in Chesapeake Urology's Bel Air and Havre de Grace offices. He practices general urology, including seeing patients with enlarged prostate, and was designated a UroLift Center of Excellence in July 2020, recognizing that he has achieved a high level of training and experience with the UroLift system, a minimally invasive treatment option for men with BPH enlarged prostate. This designation demonstrates his commitment to exemplary care. He is an active member of the American Urological Association and the American Association of Clinical Urologists. Welcome, Dr. Arrison.
Thank you, Jen. So thanks everybody for coming. Hopefully it's helpful for everybody. Basically, this is primarily going to be about BPH, prostate enlargement, how you get diagnosed and how you treat it. These are some of the things we're going to spend the time on, the importance and what the prostate is for, BPH, what exactly that is, how it's diagnosed, some of the treatment options, and then some more detail about the UroLift system itself. The prostate, a lot of people come in and quite honestly, many men who come into the office don't even know what the prostate does. Prostate is a sexual organ. Basically, when you ejaculate, most of what comes out is not sperm. Most is the ejaculate, which comes from the seminal vesicles in the prostate. Realistically, once someone is done having children, they don't really need the prostate anymore. And at that point, it really becomes more of a problem than anything else, both urinary-wise and obviously prostate cancer. You always hear people say it's a walnut-sized gland at the base of the bladder, which is true, although there can be a very, very wide variance in terms of how large the prostate can be. It does surround the urethra, so if you look at these pictures, and pretty much any picture you see is going to show the bladder, and then the prostate like this is a cross-section. So realistically, the prostate actually goes all the way around like a donut, and it's kind of like a donut that you're urinating through. The prostate grows throughout your entire life, from when you're first born, and then as you get through middle age and older is really when it starts causing more problems just because of the size of it at that point. And you'll hear me say a couple of times, we talk about prostate size. Everybody says prostate enlargement. I'll probably say it throughout the talk a whole bunch of times. That's really a very bad term, primarily because while the size of the prostate, the larger prostate is more likely to cause symptoms, there's not a direct correlate. There are a lot of people with relatively small prostates who have significant urinary symptoms, and some people with giant prostates who have barely any symptoms at all. Another thing that's important to understand, particularly when you're talking to other people, family members or whatever, is that there's a difference between prostatitis, prostate cancer, and prostate enlargement or BPH. Prostatitis is just inflammation or irritation of the prostate. Sometimes it can be secondary to an infection. A lot of times it's just inflammatory and it causes a lot of burning, frequency, urgency, a lot of urinary symptoms, but they tend to be transient, where the person might be doing fine, flares for a couple of days or a week or so, and then they kind of return to their baseline and they're doing okay. Prostate cancer obviously is cancer. Prostate cancer is a cancer that many, many, many men will ultimately develop. And quite honestly, if you live long enough and you're a guy, you will get prostate cancer. Most guys who are in their 80s will have a very indolent form of it. They very well may never need any treatment, and it's probably not going to cause any problems, but they will get it. We obviously worry a lot more about prostate cancer in guys in their 50s, 60s, 70s, and they're the ones that we will evaluate. And generally, when someone's being evaluated for urinary symptoms, one of the first things we're going to do is try to rule out prostate cancer. And then there's prostate enlargement or BPH. Having one of them doesn't mean you're going to get one of the others, but they're also not protective. So you can have none of them, one of them, or any combination of them. Prostate issues, not surprisingly, do become more of a problem as guys get older. Very prevalent, as you can see, 40 million guys each year. 70% of guys in their 60s will have some amount of enlargement, and then 90% in their 80s. Again, this is a little bit tough to evaluate in terms of it saying an enlarged prostate. That's kind of a nebulous term in terms of whether you're talking about urinary symptoms or whether you're talking about physical enlargement. Realistically, most guys will have both. Benign prostatic hyperplasia or BPH, that's essentially what we're talking about when you're talking about an enlarged prostate. It is non-cancerous. That's important to know. That, again, doesn't mean that you can't have cancer and BPH at the same time, but just having BPH does not mean that you are more prone to have prostate cancer. The PSA will rise with both, and that can be a little bit difficult. Most people know PSA stands for prostate-specific antigen, and it's a blood test that we use to look for prostate cancer. And not infrequently, if a guy has an enlarged prostate, he may not have prostate cancer, but that might still make the PSA rise. So some people may end up having to get a biopsy before you go down the path of treating their prostate enlargement, because you want to rule out prostate cancer before you go jumping into anything for their urinary symptoms. Normal versus enlarged. Basically, this is showing what we were kind of talking about earlier, that the prostate actually surrounds the urethra right at the base of it. So as it gets bigger, it kind of squeezes in on this area, which makes it harder. The first thing you're going to notice is frequently is a slower stream, things like that, make it a little hesitancy, a little too longer to go to the bathroom. But then the other thing that happens is as it blocks things up, it will make the bladder work a lot harder. As we said earlier, the size of the prostate doesn't necessarily correlate to the symptoms. Realistically, the bigger the prostate is, the more likely someone is to have symptoms, but we see lots of guys who have medium-sized prostates who still have significant urinary symptoms. If it's not treated, typically, a lot of times guys will just start noticing their symptoms and their symptoms will become more bothersome, which oftentimes is what brings them to the office and what gets them treated. Having said that, if it's not treated over time, it can cause some very significant problems. The picture here on the right is showing that the bladder muscle will get hypertrophied, and we call these things trabeculations in the middle there, these like stripes and stuff. And that's basically because the muscle has to work harder to work against the prostate. And it's just like if a guy goes to the gym and works out all the time, his muscles are going to get bigger, but he's also going to lose a lot of flexibility. And the bladder does the same thing. As the muscle gets bigger, it loses a lot of its elasticity, which ultimately leads to things like frequency, urgency, getting up a lot at night, which tend to be a lot of the more irritative symptoms. Other things that if it gets bad enough, it can back up into the kidneys, cause kidney problems, and also can cause urinary retention where someone can't urinate at all. As it progresses, they're showing basically normal prostate, mild growth, and then more significant growth. These pictures aren't exactly accurate. I'll be honest, I don't think I've ever seen a prostate that looks that wide open, even in a young person. But the idea of it is that when they're younger, it is more of an open channel to get in there. And then as the prostate grows more and more, you get more significant obstruction that blocks the person up. Some of the symptoms: frequent urination, urgency. Sometimes if it gets really bad, urgent incontinence. That's generally not a great sign. If someone just has frequency and urgency, that's very common. If it progresses to the point where they're actually leaking, that generally means that it's getting a little bit more progressive, and you don't want to wait too long because that can become permanent. A lot of the symptoms, the slow stream, the frequency, urgency, if you treat the prostate, those symptoms will get better and they'll go away. Not always, but if it gets to the point where someone's leaking significantly, even if you treat them, they still may have incontinence because that's oftentimes a sign that it's gotten pretty progressive. Weak stream, incomplete elimination of urine, even to the point of urinary retention or an intermittent stream. A lot of people already know these and either have dealt with it themselves or have had family members who've dealt with it, that they kind of either avoid travel or at least plan their travel. They plan their travel around where the bathrooms are. They don't like flying places because that means you're going to be up and down on the plane all the time. Disruption of sleep. One of the issues that I do run into a lot, though, is while sleep is one of the biggest complaints that a lot of patients have, and frequently poor sleep can be because of the prostate and the bladder, it's not always the case. And some people just don't sleep well. And when they get up, they go to the bathroom and assume that it's from the bladder or the prostate. It's not always. Some people just don't sleep well. Treating the prostate certainly can help that a little bit, but it may not make those symptoms resolve entirely. And a lot of times the evaluation we do can point to whether it's the prostate as a primary source of those problems. So how is it diagnosed? We always take a history. We do an exam. The rectal exam is giving an approximate size of the prostate. Doesn't do a great job of really telling you how big the prostate is, but we're also feeling for nodules, hard bumps. Those are things that would be more concerning for prostate cancer. I almost always do a bladder scan, or a lot of times a pelvic ultrasound. A bladder scan is just kind of like a stripped down ultrasound, and it can tell you how well the person has emptied their bladder, but that's really all it tells you. A pelvic ultrasound can tell you how well someone empties their bladder, but also gives you a much more accurate estimate as to how big the prostate is, and that can affect what the different treatment options are. Oftentimes, people will take an International Prostate Symptom Score or IPSS score. They may not even know they're taking it. A lot of times it's when you come into the office and you're doing some of the paperwork or on one of the pads before your appointment, it'll ask some questions, and that's actually what they're asking you. And it gives you a symptom score to kind of give you an idea as to how severe someone's symptoms are. Optional studies, UroFlow is a great test. That's where you actually, kind of sounds weird, but you urinate into a machine. The machine measures how strong your flow comes out. Not surprisingly, people who have more significant obstruction have a poor flow. Pressure flow studies measure the flow but also measure the bladder pressure. They're very good for telling you if someone's obstructed, but they are a little bit more invasive. To do formal pressure flow studies usually requires a catheter into the bladder, so a lot of guys don't want to do that. One of the tests we do a lot in the office now is something called a UroCuff test, which is similar. It gives you a lot of the same information, but it's non-invasive. It's basically, it's again, very weird. Looks like a little blood pressure cuff that goes on the penis while the guy urinates. They have to have a very full bladder, so we'll either tell them to come into the office with a full bladder, or I, a lot of times, like to do this after I do a cystoscopy so I can fill it myself, and then I know they have a nice full bladder. They go to the bathroom, and then as they're going, that cuff is going up and down, and that cuff measures how hard the bladder's working. So between the measurement of the flow and the bladder pressures, you can tell if someone's obstructed or not. If someone's obstructed, they're going to have a poor flow, very high pressures, as opposed to, for example, someone who might have diabetes might have a very poor flow, but it's because their bladder just doesn't work that well. And you can differentiate between those two. And it's also nice because a lot of times these symptoms are things that people have been dealing with for years, if not decades. Just asking someone, how's your flow? It's a question we all ask, but it's kind of a stupid question because it doesn't really mean anything. Someone can tell you, yeah, I'm doing well, or I'm not doing so well. And we've all had lots of guys who think they're doing very, very well. And then when we actually check them, their flow may stink. Or other people who think they're not doing so well, but when we check them, they're kind of average. And it kind of helps you decide how severe someone's symptoms are. Transrectal ultrasound is also an ultrasound. It goes in through the backside. We always do that when we're doing a prostate biopsy. That's how we do prostate biopsies. So if I know I'm going to be doing a biopsy on someone, I may or may not do the pelvic ultrasound. A lot of times, if I'm just trying to get a prostate measurement, I tend to lean towards doing a pelvic ultrasound over a transrectal ultrasound just because it's more comfortable. Cystoscopy is looking into the bladder. People are always pretty nervous about it, understandably, but it's actually not that bad. People tolerate it very, very well. Generally, we clean them off. We put some numbing medicine into the penis and we take a small scope. Only takes about a minute or two, and it's the best way to get a good look at the inside of the prostate. Those pictures that we looked at earlier that showed the kind of the prostate growing over time, they were cystoscopic pictures. That's what it would look like. This is that IPSS score. And it's basically a bunch of questions. A lot of people have probably even seen those or answered these questions about how frequently you go, how often you have urgency, weak stream, straining, how much it affects your life. And you're going to get a score based on that. That kind of tells us how severe someone's symptoms are. It's actually not only worthwhile up front because it can tell you how much someone's symptoms are bothering them, but then even down the road, once you treat them, ideally you'd like to see those scores come down significantly, and they generally do. So treatment options, there's a whole lot of treatment options. Kind of goes through the gambit from watchful waiting over here, which is obviously less invasive, all the way up to surgery. And they have it stopping here at the laser. There's even more invasive surgeries than that, but those don't happen too often. So less invasive, watchful waiting. Watchful waiting is basically not doing anything medically. Obviously, there's no side effects. There's no cost really. And it's really things like, again, knowing where bathrooms are, trying to avoid things like coffee, tea, sodas, other dietary things that may affect it. There are things, it's not really, I would say, a plan as much as it is that things that people tend to do on their own without even really thinking about it. They just kind of, as they change their lifestyle because of these symptoms, they're essentially doing watchful waiting. So this slide mixes both medications and herbal remedies. Herbal remedies here, things like saw palmetto or prostate formula, super beta prostate, things like that. Those are non-prescription things, no real side effects, no surgeries. That's some of the benefits of it. None of them have ever really been proven to do anything. There is anecdotal evidence, and I've had patients who've come in and said, hey, I went on saw palmetto and I feel like I'm doing a lot better. And that's fine. I personally have no problems with people trying those. And if they get some improvement from them, that's great. But it is important to know that none of them have ever been really proven to do anything in any good clinical trials. You know, all of them will talk about studies that show this improvement or that improvement. Most of those studies are done by the companies making the pills. So that kind of has to make you worry a little bit, or at least think about it a little bit. Some of the other disadvantage of those things is, as we said earlier, untreated BPH can over time cause deterioration of symptoms and deterioration of bladder function. So you can have that progression without really realizing it as much. Medications, Flomax is also called tamsulosin, Avodart, or dutasteride. Duodart was actually a combination of those. Cialis obviously is more for erectile dysfunction. Some people will use it for both. Realistically, doesn't work that great for BPH, but if someone has mild ED, mild BPH, you can use it and potentially kill two birds with one stone. It does work okay. Medicines don't work great. Most of the side effects are going to be specific to the medication. So for example, Flomax can cause some lightheadedness and dizziness, can also cause something called retrograde ejaculation. Avodart can cause some erectile issues, and there have been some concerns about long-term use of that and cognitive function, things like that. Plus, there's the cost. And then also these days, so many people are on so many medications that all of those have interactions. So you want to kind of be careful with that. The UroLift system, obviously, we're going to talk about that in a little bit more detail down the road. This slide says that it can be done in the office, which is true to a certain extent. The UroLift can be done either under local anesthesia or with sedation, which is nice. Having said that, it is a little bit of a more invasive procedure than, for example, a cystoscopy. So while it is a less invasive procedure, and it is probably one of the least invasive of the treatment options for BPH, it's not doing nothing at all. Usually when we are evaluating something for someone for any of these procedures, whether it's the UroLift or the shaving or the resection, we'll almost always do a cystoscopy. And when I do a cystoscopy, if I'm thinking that someone might be a candidate for something, when I do the cystoscopy, I'll a lot of times see how they tolerate that. If someone is very comfortable and has no problems with the cysto at all, they frequently can have the UroLift done under just local anesthesia. It also depends on the size of the prostate and some other anatomical things. If someone's uncomfortable during the cysto, or if their prostate's shaped certain ways, they tend to be a little bit more uncomfortable having it done under local, and I may recommend doing it under sedation in that case. Preservation of sexual function, that's a big one, particularly something called retrograde ejaculation. When you ejaculate, the prostate can push the semen out through the tip of the penis. Whenever you do anything to open it up, and that can be with medications or any of the surgeries, it can open that area up, which is what it's supposed to do. But then the semen can take the path of least resistance and go into what you call retrograde ejaculation, where your ejaculate volumes decrease. The recovery is very quick. Most people will have some irritative symptoms for a few days to a week or so, but usually within about a week or so, people are already starting to see some significant improvement. Catheters, sometimes people go home with a catheter, sometimes not, and generally last pretty long. Disadvantages, as I said earlier, some people are going to be a little uncomfortable during the procedure, but a lot of times if you kind of feel them out during the cystoscopy and based on the size of the prostate, you can pick who might be a good candidate to have it done under local versus sedation. Potential for some blood in the urine, you will have some blood in the urine. There's no doubt about that. With any of these procedures we do, you're going to have some blood in the urine, and you're also going to have some worsening of symptoms. Again, no matter what I do with patients, I always tell them that there will be a time where you're going to have more burning, frequency, urgency afterwards, generally for a couple of days to a week or so. Heat-based things, TUMT was a form of microwave therapy where you dilated it and used microwave energy to try to heat the prostate and shrink it down. Tuna was used a lot a few years ago, kind of fallen out of favor because quite honestly, the Rezum works better than the tuna. They're all kind of doing the same thing. They're basically putting heat into the prostate with the idea that the heat will kill the tissue and then it'll shrink away. These days, the Rezum is certainly used much more than either the TUMT or the tuna procedure. And that's primarily because it does work better than either one of those two. These are office-based procedures. The main downside of these procedures is because you're putting heat into the area and treating it that way, the prostate swells a lot first. Those symptoms of frequency, urgency, slower stream, potentially having a catheter, they will last longer with these procedures than they will with the UroLift or with the shaving. Major surgery, they have TURP, green light laser. These are considered bigger surgeries. I don't know if I would consider them major surgeries. And that's where you're actually physically removing the tissue. It does definitely maximize the flow. There's no doubt that these procedures will give a better flow than any of the other ones, including the UroLift. So if someone does have a very large prostate, or if they have a big median tissue or things like that, they're going to do better with this because you are physically removing tissue. Having said that, it is a more significant procedure. It definitely requires general anesthesia. They say it's a hospital-based procedure. We do these in our surgery center all the time. They are outpatient typically. Occasionally people have to stay overnight, but most times these can be done as an outpatient. You do have to have a catheter in generally for a day or so. So you will, and the retrograde ejaculation rates are higher. Some of the risks, scar tissue, things like that are certainly higher with these. So the resection definitely works better if someone's in really bad shape. If I have a guy who has a big prostate and he's got a catheter in and he can't urinate at all, I'm still going to lean towards this over something like the UroLift. But for the majority of people who are out there who don't have these gigantic prostates, have medium-sized prostates, medium to moderate symptoms, it does a very good job. The UroLift is going to be a little bit less invasive and still give you some good benefit. So the UroLift system, basically this again is similar to the pictures you've seen before. This is your bladder up in here. You urinate down through the urethra. And again, you have to think of this as a three-dimensional picture so that the prostate actually encircles the urethra. Essentially what you do is you go in and you put these little clips in. These clips have an anchor, and then this is a suture, and then another metal, this is a stainless steel clip. And basically by putting them in, you're compressing the tissue. So you're not physically removing tissue, but you are compressing it, but you're opening it up right away. And again, when we talked about those other ones, the steam-based procedures, you actually put the steam in this area. So while it does treat the prostate well and it eventually shrinks away, you're not opening it up right away. So they do tend to have a lot of hesitancy afterwards until that steam has a chance to work. This one, while you still have the frequency and urgency, you are opening it up right away. So they do have a quicker response to the treatment. This is a close-up picture of it. Nitinol is a metal alloy of nickel and titanium. So if someone has a nickel allergy, they shouldn't get a UroLift. I've only had one patient not be able to get a UroLift because of a nickel allergy. And that was kind of found fortuitously. I didn't even realize he had it. And one of the nurses asked him and he said something about a nickel allergy. But other than that, almost anybody can get these. This one's stainless steel and that's just a suture in the area. This is the cystoscopic view. So this is looking in with a scope beforehand where you have the prostate coming in from either side. And this is afterwards where it's much more open. And essentially you can almost see like a divot over here. So you can't see it, but there's a clip up here. There's going to be a clip over here. There's going to be a clip back in here. So you can kind of see where those divots are. And that's where those clips were placed. Symptom improvement within a couple of weeks, but I do always tell people with any of these procedures that there will be a time that they wonder what they got themselves into. Usually post-op day 1 or 2, people are kind of like wondering, they're having lots of burning, frequency and urgency. You have to be a little bit patient, but it's just like anything. You get your knee operated on, you shouldn't expect it to feel great the next day. It's going to take a little bit of time, but most people will notice a significant improvement in their flow, first of all, and then things like frequency and urgency get better after that. As I said, burning and urination, blood in the urine, some pain, usually not a lot of pain. We honestly don't even give people pain medication. Most people don't need it. We do usually give something for burning in the urine, and then the urgency, fortunately, particularly with the UroLift, goes away pretty quickly and also has a durable response. I'll be honest, I'm not the best insurance guy in the world. Most of these are covered very well. Realistically, I think insurance companies don't like the idea of someone being on medicines forever. So if they can pay for something and have them done, hopefully with medicines, that's a good thing. Some of them will tell you whether it has to be done in an office-based setting or a surgery center setting, but for the most part, coverage is very good for these. So available for consultations up in the Bel Air, Have the Grace office, myself, Dr. Kausick, Dr. Van Zale, Dr. Cleary, we all do all of these procedures and all do a lot of them. And they work very, very well. If you're already seeing one of us, you can certainly ask us about it. Hopefully you've already heard about it if you're already seeing one of us. If people are seeing and being seen in a different office or in a different practice, certainly in some of the other offices, there's almost doctors in every office who do a lot of these procedures. So this is not something that is not available to pretty much anybody. One of the things you do have to realize, it says find the solution that's right for you. And that's true, because I as much as I do like the UroLift, I think it's a great procedure, works great for a lot of people, but it's not a panacea. And you do get people who come in saying, oh, I want a UroLift, I want to resume, I want this, I want that. And that's fine that they've done some research and that they know some of the stuff, but realistically, you still have to know how big their prostate is. You have to know what the shape of their prostate is. You have to know about their other medical issues, because if you just say, yes, we're going to do this and you're going to jump into it, they may ultimately be disappointed with their results. This is actually from the UroLift website. So anyone could go on to urolift.com because that other video wasn't working. And this is similar. This is a picture of inside the prostate, again, a cross section of it. This is the scope that's in there. So to do the procedure, essentially what happens is you compress the prostate, you deploy the base, and then you deploy the tip. You turn around, do it on the other side. Same thing, you get the anchoring one, the suture, and then the urethral side. And most people will get either 4 or 6 of these. Occasionally someone only gets 2, but most people are going to be more like this picture where you're going to have 4 or 6. And the idea of it is to open it up similar to that.
Thank you for joining us for tonight's webinar. You may also want to visit Chesapeake Urology's YouTube channel, where you can find a full catalog of informational videos and webinar recordings. Dr. Arrison sees patients in our Bel Air and Havre de Grace offices with both in-office and telehealth appointments. For more information or to make an appointment, please visit us at chesapeakeurology.com, where self-appointment scheduling is now available. Thank you for joining us and have a great evening.